Alrighty, week 3, GI drugs. Okay, so the colon absorbs a bunch of water and electrolytes, minimal absorption of nutrients, and a ton of water enters the colon on a daily basis, and 90% of that fluid is absorbed. Normal frequency of bowel elimination varies widely. Some people have 2 to 3 times per day. Some have 2 times per week. We don't really like to see much longer than 2 times per week, but some people have that. So when we have an increase in transit time, move this thing. Okay. When we have an increase in transit time, that's going to lead to more fluid being absorbed through the colon. So think of it like and this is going to be a terrible analogy. When we take a batch of brownies and we put them into the oven and we set that timer for 4 hours, we've got some really, really, really hard brownies. And they're going to be really hard to get out of that pan, and they're just going to be a pain in the butt, and they're going to be really nasty. So increased transit time through the colon is going to lead to excessive fluid absorption in the colon, leading to a very hard and compacted stool. On the opposite side, if we take those brownies, we put them in the oven for 5 minutes, decreasing the transit time, we pull them out, they're going to be all kinds of moist and mushy and just overall, and they're going to taste great, but they're going to be really nasty because they're going to be all liquid. Same thing for here. If we decrease the transit time going through the colon, there's going to be a lot less fluid absorption pulled out of the stool, leading to a very loose, wet stool. So diarrhea. So constipation, diarrhea. All right, so dietary fiber is important for proper function of the bowel. Bran's a beautiful source for this. It absorbs water, which will help to soften stool and increase the size. And you may think increased size may lead to more constipation, but it's an increase in size with a soft stool, which can help to allow for peristalsis to occur, pushing the poo through the colon better, rather than getting stuck. It's when we have those firm, compact, not very malleable stools, regardless of size, that make it very difficult to push through the colon. Fiber is digested by colonic bacteria, and the growth of that will increase the fecal mass. And a low-fiber diet, as is common in this country, is a frequent cause of constipation. And so constipation is one of the most common GI disorders, with hundreds of millions of dollars spent on laxatives per year, a lot of which are from the older generations. And constipation can come in many different forms. It can be hard stools, infrequent stools, excessive straining, prolonged effort, a sense of incomplete evacuation, so you feel like you got stuff in your butt still. Laxatives come in as a purpose to try to ease or stimulate defecation. And there are 4 ways or mechanisms of action we can have for trying to ease or stimulate defecation. We can either soften the stool as a stool softener, increase the stool volume, hasten that stool's transit time, making it so that it retains more fluid, or facilitate evacuation from the rectum. So we can have different indications for using laxatives. For example, if we need to have why aren't you working? Come on. If we need a stool sample, we can use a laxative to help get one out. Before a treatment or procedure where we need to go up, or if we need to not want to worry about having stuff coming out while we're in mid-procedure. Of course, constipation. To prevent impaction in immobile patients, so patients who are bedridden from perhaps after surgery, especially if they're on opioids, they're going to be at high risk of having compaction or impaction. And so taking them prophylactically would help a lot. Almost every patient you're going to see in the acute care setting is going to be on some kind of, or at the very least have a PRN laxative of some kind. And then to remove toxins. Contraindications to using laxatives are going to include unusual abdominal pain or not knowing what that is until we've ruled it out and have a reason for why to give it. We don't give it if they have abdominal pain. If they have nausea, cramps, diverticulitis, or ulcerative colitis, we will not give it. If they were post-surgical abdomen, if they just came out of having surgery on their abdomen, we're not going to give laxatives. If they have a definite fecal impaction or obstruction, we're not going to give it since that's just going to make the matter even worse, if not lead to, what's the word? Perforation. If there's a history of habitual use, we're not going to give laxatives, and we're also going to be very careful to give it in when a woman's pregnant or lactating. So we have a few different specific laxatives here. We've got a bulk forming or psyllium or Metamucil, a surfactant laxative, also known as docusate sodium or Colace, a stimulant, bisacodyl Dulcolax, osmotic polyethylene glycol, and Miralax. So psyllium or Metamucil is similar to dietary fiber. It will swell with water. It'll form a gel, soften stool, and increase mass overall. So it works great. It's a lot like a dietary fiber, natural. It's the preferred temporary treatment of constipation, diverticulosis, and irritable bowel syndrome. Notice it says diverticulosis, not diverticulitis. So when we have diverticulitis, we don't give it. And then with irritable bowel syndrome, commonly these people end up being constipated or they have diarrhea. If it's on the constipation side, then we can give them this. There's minimal adverse effects. For every single one of these laxatives, there's going to be the potential for GI obstruction or for diarrhea. So always know that. And cramps, because we're going to be having stuff kind of going through and activating peristalsis. Docusate sodium. This inhibits fluid absorption. This is a surfactant. So this is going to coat kind of something. I'm not sure if it coats the intestines or the food, the bulk itself. But there's going to be a decrease in fluid absorption. So we're going to have an increase in water and electrolytes within the intestinal lumen. So we're going to have more water being retained by the stool before it goes out, making it so it can pass through the intestines more easily. So we're going to use this to soften stool. Adverse effects, we're going to have electrolyte imbalances because of the fact that we're increasing water and electrolytes within the lumen. So we're disrupting that water-electrolyte balance that naturally occurs. I need to correct myself. GI obstruction is not normal for each one. Some of them have that. What is there for each one is the potential for diarrhea, which is kind of an obvious. Bisacodyl is going to be our stimulant laxative. It can be given either PO or per rectum, and this stimulates intestinal motility, so gets stuff kind of moving faster. And so there's going to be an increase then of water and electrolytes in the intestinal lumen, since things aren't going to be sitting there long enough to be absorbed like our overbaked brownies. So this is going to be used for short-term constipation and when there's slow intestinal transit time. So if a person, for whatever reason, naturally has slower intestinal transit time, this would be a great option as sort of like a long-term solution to that. So this is widely abused for the purpose of trying to lose weight, has a great potential for making electrolyte imbalances. Of course, there's going to be cramps and diarrhea, and it's contraindicated with impaction, which kind of goes for most, if not all of these, since impaction would indicate that all this movement is just going to build up, build up, build up behind that impaction, leading to perforation. And then we have our osmotic laxative, which is going to be polyethylene glycol, or Miralax. So this is non-absorbable, which is good, and draws water into the lumen by being an osmotic laxative. So an osmotic force is one that pulls fluid, water, towards a solute, basically, kind of like salt. So what happens is all this water gets pulled into the lumen, and the fecal mass then will soften and swell. And the lumen then will stretch, which will stimulate peristalsis. So kind of that stretch reflex inside the lumen. This will be used as a more regular use of chronic constipation. We have, of course, some typical adverse effects, bloating, cramping, flatulence, diarrhea. We'll also potentially have nausea, dehydration with substantial water loss. So if we're taking a lot of this and just kind of go a lot, then there's a potential for dehydration, especially if there wasn't adequate fluid intake in the first place. Electrolyte imbalances can occur because water comes in, salt may have less of a desire to be pulled into the or through the intestinal walls. And this may exacerbate heart failure. Actually, I'm sorry. The electrolyte imbalances can occur from the fact that the water is being pulled into the lumen, making it so that there's a higher concentration outside the lumen. And that can exacerbate heart failure, hypertension, and edema. And it's also contraindicated in kidney disease since as we have a higher concentration of solute, the kidneys have to work that much harder to get fluid to go through. And if it's dehydrated, if the person's dehydrated, then they're going to have less actual renal blood flow through the kidneys. It's a wonderful background image. Bowel cleansing products for colonoscopy. This is to allow for good visualization of the bowel because we don't have a need to look at poo. We need to look at things like diverticulosis or abnormal growths. So we have a couple options. We have sodium phosphate and polyethylene glycol plus electrolytes, which I used to think stood for go telly instead of go lightly, like most normal people would probably consider. Sodium phosphate is our saline laxative. This is hypertonic with body fluids to help promote more fluid accumulation within the bowels and then flush everything that's in there out. But of course, that can cause dehydration and electrolyte issues. There's also the possibility through the dehydration of causing renal damage. Polyethylene glycol and electrolytes are isotonic with the body fluids, but instead of having it as a, I believe this one is actually as a enema, as you can see in this wonderful image. This one is taken orally, and so we drink it, and it's about like a gallon of fluid, and it's supposed to taste horrible, and it gets you to go a lot, so that you can get to flush everything out of there. So laxative abuse, that can come from a misconception of bowel movement frequency. So a lot of older adults have sort of this misunderstanding of how often should they be really expected to go. We can also have a problem with thinking that the time it takes to replenish the bowels indicates an issue with constipation. If someone's had a really big bowel movement, or perhaps they used laxatives to help clean out their bowels, they may think they have constipation after that due to the fact that it can take 2 to 5 days to replenish the bowels after such a large movement. And then weight loss is an issue because people want to lose weight and they think pooping it all out can help lose weight. If we have a decrease in defecatory reflexes, then that can lead to further reliance on laxatives. We can also have electrolyte imbalances, dehydration, colitis, inflammation of the colon, and malnutrition from just simply not having enough, a time for the product to stay within the colon to be absorbed, to absorb the nutrients it needs. Hello, there we go. So tips to relieve constipation: diet, including adequate hydration, changes in lifestyles. We need to be more active to help. Um, when we have bulk-forming laxatives, take with water or juice. We can use stimulants to discourage abuse. Stool softeners, make sure you take with water. Lubricants and saline laxatives. And we want to make sure that we're teaching about the adverse effects, including how to avoid kidney disease when we have electrolyte disturbances. Okay, now on the other end of the spectrum, we have diarrhea, so excessive stool volume, fluidity, or increased frequency of defecation. So we're going to have this as a symptom of GI disease when we have infection, maldigestion, inflammation, or functional motility disorder. Some of the complications of this is going to be dehydration and electrolyte depletion, since we can have a lot of electrolytes being being expelled out of our body via diarrhea. Maybe I said that wrong. This can be a symptom of GI disease during infection, maldigestion, inflammation, and functional disorder. Yeah, whatever. Management. So we want to treat the underlying disease. So if we're talking about, like, let's say the person has an infection. So we want to go about treating that with, if it's bacterial, treat it with antibiotics. We want to then also hydrate and replenish the electrolytes, since that can lead to even greater issues, relieve cramping, and then decrease the passage of unformed stools. The two major drug groups, why do I have, nope, that's not what I want. Why is that there? Stop. Get rid of, and you go away too. Non-specific antidiarrheals and specific, antidiarrheals. So, actually, I don't remember the difference. I think that note was for myself. Okay, so specific diarrheals are going to be the diarrheals, antidiarrheals. Specific antidiarrheals are going to be the ones that affect the underlying cause of diarrhea. So if it's a bacterial infection, it'll be the antibacteria or antibiotics that we use to treat whatever's causing the infection. If we're looking at just something that treats the diarrhea itself and not the underlying cause, then that's a non-specific antidiarrheal. So for non-specific antidiarrheals, we have loperamide or Imodium, which is, I believe, over-the-counter. This is actually an opioid, but it doesn't quite work in that same way. So it activates mu-opioid receptors in the GI tract rather than systemically. And what it does is it decreases intestinal motility to slow the transit time. This allows for an increase in fluid and sodium absorption. So we take a lot of that fluid that would normally be in the intestines at that time, and we absorb more of it as if we left our brownies in there at, an appropriate 20 minutes, 25 minutes, however long the directions say. And now we got our perfectly fluffy, moist brownies, and not too runny. So we're going to use this for diarrhea when the etiology has been identified. So we want to make sure that this isn't, for example, a bacterial infection, because if it's a bacterial infection, like let's say C. diff, we may not want to go about trying to reduce it with loperamide, because that's a potentially beneficial measure that the body's taking. As for adverse effects, there are little to no abusive potential because it's poorly absorbed. So it goes in there, causes its stuff, and then gets out. But within the spectrum of like the local issues, We can have constipation from it working too well. We can have paralytic ileus, which is where a section of the colon or small intestine no longer produce peristalsis. And then urinary retention, though I don't quite remember why that is. So infectious diarrhea will be treated with some sort of a specific anti-diarrheal. Normally we have like a bacteria or protozoa that's responsible. So protozoa, I believe that'd be like Giardia is a protozoa. The infections are usually self-limited, but we will use antibiotics when clearly we need to, so C. diff. All right, antiemetics are given to help with nausea and vomiting. That can be from chemo, from pregnancy, from motion sickness, toxins, surgery. And that stands for chemotherapy-induced nausea and vomiting. There are many receptors involved in trying to control nausea and vomiting. There are serotonin, glucocorticoid, dopamine, acetylcholine, and histamine. And a lot of these antiemetics are going to interact with one or more of these receptors. Ondansetron, or Zofran, is going to be one of our most common anti-diarrhea or antiemetics. This is going to be a serotonin antagonist, so it blocks serotonin receptors on the vagal nerve. And dexamethasone, which is a steroid, is going to have a pronounced effect, or is going to create a pronounced effect when mixed with ondansetron. This can be given PO or IV, and I think we even have a sublingual tab, or tablet to use as well, which is great for those who can't feel like they can swallow. Adverse effects are going to include things like headache, diarrhea, dizziness, dysrhythmias, very mild overall. Though we want to be cautious with people who have cardiac issues, since this can promote QT syndrome. So if they have cardiac issues, they're going to be a higher risk for dysrhythmias from QT syndrome. Getting distracted because my freaking cat keeps on bothering me. Let's chill. All right, stop. Okay, antiemetics. Promethazine. Okay, promethazine is a dopamine antagonist. So Zofran was a serotonin antagonist. Promethazine is a dopamine antagonist. This will block dopamine 2 receptors in the chemotherapy trigger zone. And it can be given PO, IV, IM, or per rectal. Stop. The adverse effects are going to include extrapyramidal symptoms, which are things that you're going to learn more about. Oh my God, would you please stop? You're going to learn more about those when we get to psychotropic, and then when you get to, what is that other one? Crohn 2 with mental illness. But in general, extrapyramidal symptoms, the pyramidal centers of the spinal cord, I think it is, or areas that control certain parts of the body. I think it's the motor units, and stimulating those areas can produce different kinds of movement disorders. So, for example, we can have akathisia, which is an inability to hold still. We can have acute dystonia, which is where, for example, the most common that I've seen is where like parts of the neck, muscles in the neck start to seize up, and a person may have their neck cocked to the side or their head turned to the side, and they can't really relax it at all. There can be Parkinsonism, where symptoms represent or reflect what a person would have with Parkinson's, but the person doesn't actually have Parkinson's. And then another one would be like tardive dyskinesia, where a person has this sort of worm tongue kind of thing, where it kind of twirls in their mouth, they kind of smack their gums a bit, or their lips, and that one's kind of permanent. These are all kind of things that you'll experience with extrapyramidal symptoms, and you'll learn more about that later. We can also have urinary retention, hypotension, and sedation from taking promethazine. Sedation is kind of a nice thing in that people who are nauseous and a little anxious, that sedation might help to take care of both at once. We do want to be cautious in giving it to children who are at risk of respiratory depression, since the sedation can lead to a more pronounced respiratory depression. We also have a prokinetic, and I don't know why it's called prokinetic, but I do know that it blocks both dopamine and serotonin, and it's metoclopramide, or Reglan. It is only for IV, and it blocks the dopamine and serotonin receptors in the chemotherapy trigger zone, and it also enhances acetylcholine action. Don't know how useful that is. It also increases upper GI motility. So some of these adverse effects are going to be diarrhea, probably from the upper GI motility increase, sedation, extrapyramidal symptoms, of which tardive dyskinesia is one of them. It is contraindicated in patients who have GI obstruction, since it increases the upper GI motility, the elderly, and it's cautious in taken for long-term use. Dronabinol is a cannabinoid. It is related to marijuana, and the action is unclear. There is a potential for abuse, being that it is related to marijuana. It can create some psychotomimetic effects. For example, temporal disintegration, dissociation. It can also cause hypotension. So, with that being the case, it's contraindicated in patients who have psychiatric disorders, and it's also contraindicated with other sedatives. Scopolamine comes as a patch, and it's a common one to be given as an antiemetic on cruise ships. It's a muscarinic antagonist, which is also another way of saying that it blocks acetylcholine, or is an anticholinergic, as is anticholinergic. It's used for motion sickness, like on a boat. And as such, it has the common anticholinergic effects, or side effects, as dry mouth, blurred vision, drowsiness. I wouldn't be surprised if it also caused some urinary retention and constipation. Those are pretty much the common anticholinergic side effects. Dimenhydrinate, also known as Dramamine, which you might recognize from over-the-counter, is also an antihistamine and an anticholinergic, so it blocks acetylcholine and blocks histamine receptors. Also used for motion sickness, and has the same typical side effects of anticholinergic drugs. Okay, now we're moving on to peptic ulcer disease. So when it comes to peptic ulcer disease, we have both aggressive factors and defensive factors. And an imbalance between these can lead to the production or the development of peptic ulcers. So aggressive factors are going to be things like infection, that wasn't what I wanted, infection with H. pylori, or using NSAIDs, using acid, having a lot of acidic foods, perhaps, having extra pepsin, smoking, and smoking is a big one. The defensive factors are going to be things like mucus. Mucus along the walls of the stomach help to protect it against the acidity of the stomach. Bicarbonate is something that's released to help regulate the pH of stomach acid. Blood flow and prostaglandins are also going to help in combating immune or inflammatory sort of processes that might lead to peptic ulcer disease development. So the goals of drug therapy are to alleviate the symptoms, of course, promote healing, prevent complications, and prevent the reoccurrence. We want to create conditions that are conducive to healing. So some of these anti-ulcer drugs are going to include antibiotics if we have H. pylori, to take care of H. pylori, considering that's the etiology, the root cause of peptic ulcers in that case. So metronidazole would be the drug of choice for that. Antacids can be helpful for sort of minor heartburn, since they can help to neutralize gastric acid. The common ones for their active ingredient are going to include calcium, magnesium, aluminum, and sodium bicarbonate. We also have anti-secretory agents to help suppress acid secretion, and these can include histamine type 2 receptor antagonists and proton pump inhibitors. We also have cytoprotectant medications, which help as producing a barrier over the ulcer. So this would be sulgrafate. And then we have misoprostol, which I don't think we actually have any information on, which is both an anti-secretory and enhances mucosal defenses. I think that's literally all there is to memorize for that one. So for NSAID-induced ulcers, risk factors are going to be people who are over 60 years old, have a history of ulcers, or have a high dose of NSAIDs that they use every day. For these, proton pump inhibitors are going to be our preferred method, since proton pump inhibitors are going to suppress acid secretion. We're also going to want to discontinue NSAIDs if possible to try to remove the root cause of the problem here. For ulcers that are H. pylori associated, all patients are going to be giving a 2 minimum antibiotic regimen to decrease resistance development from H. pylori. And so this is going to be in all patients who have gastric or duodenal ulcers and have a test that confirms that they have H. pylori. We're also likely to give an anti-secretory agent to help promote an environment to allow the ulcers to recover. The non-drug therapy for ulcers is going to be promoting a diet of 5 to 6 small meals per day to decrease the fluctuations of the pH in the stomach. We're going to want to tell them to avoid smoking, avoid taking aspirin or any other NSAID, because that's only going to make the matter worse, as well as alcohol, which can also promote some level of peptic ulcer inhibition of recovery. So direct treatment of peptic ulcer disease and GERD as well are going to be antacids, which we already covered what those are. These alkalinize the gastric content, not to an extreme, but they help to reduce how acidic they are, making them less painful and less capable of causing damage. This decreases the destruction of the gut wall by neutralizing the overly acidic environment. It may even enhance mucosal protection by stimulating prostaglandin production, and prostaglandins help to promote, in general, mucosal protection. They do not alter systemic pH, with the exception of sodium bicarbonate. So if you go about looking at the different active ingredients in the different types of antacids they have on the shelves, pick one that's not a bicarbonate compound. The sodium content in sodium bicarbonate and any others, if they happen to have sodium, can promote renal impairment. So keep that in mind. When it comes to histamine 2 receptor antagonists, we have a few over-the-counter flavors available to us. So the generics are cimetidine, famotidine, and ranitidine. These are going to help with gastric and duodenal ulcers and are also a first line for GERD. They work really well, they're all equally effective, and they don't really have much in the way of side effects. They promote both inhibition of gastric acid secretion, which helps with the aggressive factor aspect. They also help with promoting defensive factors through stimulating the gastric mucus secretion and synthesis, so that there's more of that natural barrier between the acid and the walls of the stomach. So the one prototype that we're going to be looking at, cimetidine or Tagamet, actually, are there more than? No, just the one. What are you doing? Okay. So the absorption of it is slowed when taken with meals or antacids, which doesn't make much intuitive sense, but I'm assuming that means that you're going to have to take it before your meal so that you are ready to go and it's absorbed and ready to work. Treats gastric and duodenal ulcers, GERD, and heartburn. Unfortunately, there are some sometimes weird adverse effects. So there are some anti-androgenic symptoms, such as gynecomastia, which is developing breasts on a man, as well as impotence. And then we can potentially develop pneumonia. I don't really understand why, as well as CNS depression and confusion. I don't really understand all of that, but that's okay, as long as you guys pass the test. Proton pump inhibitors are going to be omeprazole or Prilosec, which a lot of people probably have already seen on the shelves after it became common for a over-the-counter medication. This is a anti-secretory agent, and so it suppresses gastric acid secretion, and it's the most effective anti-secretory agent. So in this case, absorption is slowed if taken with meals, and there's difficulty crossing the blood-brain barrier. So if we really want to get the full potential, then we're probably looking at having to take it a little while before we actually have our meal. So therapeutic uses, we're going to be using it for GERD, gastric acid, or gastric and duodenal ulcers, to prevent stress ulcers in the ICU, and with NSAIDs. So that's one to remember is, if you have a question regarding you got a patient in the ICU who's at risk for developing a stress ulcer, which medication are you going to go with? You're going to go with omeprazole or Prilosec. No. Am I have been saying it wrong? Oh, these are spelled differently. Omeprazole, Parazole. Okay. All right, so adverse effects, they're going to be minimal with short-term use. More long-term use, we're looking at headache, rebound acid hypersecretion, which is no fun, pneumonia, diarrhea, and maybe bone fractures. That's where the literature seems to have hinted lately, or in the past, but now they're saying, no, there's no real worry about this, so you can better educate your patients who bring it up as a potential concern. For our cytoprotectant, sucralfate, which helps to build like that barrier in the stomach, this medication undergoes polymerization, leading to a viscid gel that creates a protective barrier on ulcers. So, it's literally just a protective layer between the ulcer and the stomach acid, creating an environment where the ulcer then can be allowed to recover. It protects it up to 6 hours and is not absorbed systemically, which means it's relatively safe to give. Come on. The only adverse effect is going to be constipation. We can also use it for acute ulcers and as maintenance therapy to prevent further development of ulcers for those who are at high risk of developing ulcers. Taking them with antacids, though, may interfere with the effects of the medication. All right, and then for drugs for IBD, we got to remember that IBD is a permanent chronic condition. Ulcerative colitis, Crohn's disease, these are not diseases that we are going to be able to cure. But we can limit how much they affect us. So we're going to be using things like glucocorticoids, aminosalicylates, which are going to help to reduce inflammation, immunosuppressants or immunomodulators, and then antibiotics for any time that we have a infection related to IBD. If it's bacterial based, we'll use antibiotics because they're going to be at that much more of a risk of it getting really severe. And aminosalicylates themselves are actually specific to the gut. They're really good for reducing inflammation, specifically in the bowels. And so I think they're really only ever used for IBD.